Last week, a friend of mine died of a heart attack. It's really sad because he's only 38 years old. It wasn't a surprise. He'd had stents placed when he was 33. The doctor told him, you need to eat better, you need to stop smoking, you need to take the medicines as prescribed, but he didn't listen. He had good health insurance. His work provided all these opportunities for him to get healthier, but he just didn't do it. His wife is left with all these medical bills and kids to raise. I don't really feel sorry for him. He made his decisions, and now he died young, and he left bills in wake of despair. That sounded kind of cruel, and that rhetoric seems ridiculous. But if we replace the words heart attack with heroin overdose, we hear that all the time in our society. My name's Carolyn Greer. I'm a physician. I work in addiction medicine and take care of people with substance use disorders and mental health. Society today should not have difficulty with comparing people who have certain things like cardiac disease, diabetes, asthma, and substance use disorders. When we think about it, they're very amenable to things like prevention, diagnosis, treatment, and why they can't be cured usually. They're all do very well with treatment, and they can have a productive life as well as they're offered measures to manage their disease. However, people with substance use disorders usually are not afforded the same kind of ongoing care as those with other chronic diseases. They're stigmatized, and that stigma will keep people from being diagnosed in the first place. It will keep them from getting appropriate treatment. It'll keep them from, once they get that appropriate treatment, being able to maintain that, and it'll keep them from staying in recovery. You might say, well, how's this affect me? I'm not a doctor, I'm not a psychiatrist, I'm not a mental health provider, I don't have anyone in my family who's affected, I don't work in community services. In 2017, there's 21.8 million people who meet the criteria for a substance use disorder. So that's like 8% of our adult population in the United States. So you do have contact with someone who is struggling with this. You definitely have contact with a family who is struggling with a substance use disorder. And today I want you to examine, what are your preconceived notions, what are your thoughts, what are your opinions, what have you shared already within your circle, within your social media platform, within how you view policies and funding, on how we address this epidemic, not just in our community, but within our whole national structure. And maybe I can convince you to look at it a little bit differently. In the early 90s, Nora Volkow, who's the director of the National Institute of Drug Abuse, beautifully illustrated that when drugs of abuse are introduced to the brain, they permanently, or not permanently, but they do damage parts that we have that address how we respond to things like reward and motivation, and also parts of our brain that help us make decisions. One part of our brain, sort of primitive, the limbic system, we share this with like earthworms and salamanders, and this helps us respond to things like memories and music and reward. And that part is, we could liken to sort of like the gas pedal, that this helps us go, 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 and we don't really think very much about what we're doing. The other part of our brain, the prefrontal cortex, that's the part of our brain that helps us say things like, that's dangerous, don't move forward, or maybe I need to save money to pay for my mortgage. That would be sort of like our brakes. And that part is sort of stunted with substance use. So when we look at someone who is struggling with a substance use disorder, it makes sense to see that they're doing things without really looking at the moral compass. Substance use disorders, Dr. Volkow demonstrated that when that drug is introduced, this imbalance occurs, and it doesn't go away once the substance is removed. But the good news is, eventually that balance returns with treatment and abstinence. So, who does this happen to? If I took 10 people in this audience today and I gave them 60 tablets of Percocet, I can tell you statistically, 8 people would take some of them and say, I have a headache, I feel nauseated, itchy, and they'd throw them away and use Tylenol. But statistically, 2 people would maybe say, you know what, that gave me some energy. I feel like cleaning my house. I feel like the depression I may have experienced is sort of removed a little bit. And they may call my office and ask for a refill. And if it was in the 90s or the early 2000s, they would get a refill and another one and another one. And they might be statistically, the people who would develop an opiate use disorder. Are those 2 people somehow weak and those 8 people have moral superiority? Well, no. We know there's some factors that go into who develops a substance use disorder with exposure and those who don't. The first one is genetics. We know that probably about 50 to 80% of developing a substance use disorder has to do simply with who your parents were. And now with the advent of 23andMe and Ancestry.com, we're going to probably have a lot more information on this. But when I ask patients, anyone else in your family affected by substance use disorder, the answer is usually in the affirmative. We can go back all the way into 1842, and even Abraham Lincoln, when speaking to the Washingtonian Society, which was a temperate society, sort of a precursor to AA 100 years later. He said, "In my judgment, those who have not fallen victim to alcoholism were spared more by the absence of appetite than to have any moral or mental superiority over those who have." He knew about this well before Dr. Volkow did any studies of the brain. The second thing is trauma. Women who are in treatment for a substance use disorder report 75% of report being victims of sexual or physical abuse. If you think in your typical cohorts that you run with, do you think that 3 out of 4 people that you run with will tell you they have a history of being sexually or physically assaulted in their life? Obviously, those statistics are very skewed for a population that's been affected by this disease. If a woman is sexually or physically abused, they are 26 more times likely to suffer from a substance use disorder in the future. And trauma is not limited to just sexual and physical abuse. We know that traumatic events such as being arrested, incarcerated, being involved with the Department of Child Services, having emotional neglect, physical neglect, educational neglect. And those traumatic events don't have to be in the past. Sometimes those events are just ongoing in your adult life. Sometimes life is just so painful that substance use occurs because regular life is too rough to be in at the moment. Richard Ruhold is a senior vice president of clinical services where I work, and he says, instead of asking people what they did, why don't we start asking them what happened to them in the first place? The third contributing factor that determines these 2 and these 8 often is just the timing of the exposure. We know that that part of the brain that helps you make decisions like don't do this, do this, doesn't really fully develop until you're about 25 years old. So when I tell my 19-year-old daughter, start acting like an adult, that's not really an accurate statement. We know that when people are exposed to substances that are mind-altering, like e-cigarettes when you're 14 years old, or controlled drinking in your parents' basement when you're 16 or 18 years old, that they are damaging that development of that system, and they aren't going to have a break developed when they are exposed to these substances earlier on. But the biggest risk that we have right now is not the death of drug poisonings, which we do struggle with. Our biggest risk is just the stigma that's associated with diagnosing people in the first place. I don't know anyone who was afraid to talk to their doctor about, I have a lump in my breast, or I'm really thirsty and tired all the time, I might have diabetes. But bringing up substance use is this taboo thing that we don't ask and you don't tell. I saw a patient a couple weeks ago. She hasn't seen her baby in a year. When she delivered, the cord blood was positive for fentanyl, which is a synthetic opioid similar to heroin. I asked her, when you were pregnant, did your doctor ask you about drug use? And she said, well, I filled out a checklist and it said, do you smoke? And I said, no, even though I do. Do you drink alcohol? I said, no. Do you use drugs? I said, no. I said, did anyone review those with you? She said, no. She goes, and I knew if I checked yes, I was afraid that they were going to swoop in and take my other children away from me, and I would have a black check and they would take my other baby away from me. And that is the pervasive feeling among women who use drugs, is that they will be bad mothers and their children will be taken away. That was what her impression was of how it works. And I role-played situation that could have happened. What if her doctor had taken the time to talk to her, which is recommended by the American College of OBGYN for every patient, not just people who look like they might use drugs, every OB patient, to say, parenting children is hard. Pregnancy is a great time if you struggle with using substances, whether they're prescribed to you or not, drinking alcohol. This is a great time to get better. We can make you healthier for your baby. She said, I would have leapt at the opportunity to get treatment. And then after she had the baby, she was told by Department of Child Services, you can't see your baby until you stop using drugs. Well, how is she going to do that without treatment? This stigma keeps me from appropriately treating these people who are affected by this illness. I spend so much time on the phone with judges, parents, halfway houses, concerned family members, explaining why I'm using evidence-based practices to take care of people. I hear things like, you're just using one drug to replace another. You're giving them a legal high. It's difficult to prove a negative. Our evidence shows that people who have an opiate use disorder, who are treated without medications, have a 90% chance of returning to use within 6 months. Doesn't mean that everybody needs to, but it certainly means that it needs to be considered. The stigma of which patients who are in treatment for opiate use disorders keeps them from staying in treatment. I know of no other diagnosis where people are siloed into a particular category. We don't have a depression clinic, a bipolar clinic, an anxiety clinic, but we sure do have an MAT clinic. We don't make patients sign a contract before they're seen for me for a major depressive disorder that says things like, I will not be verbally abusive to the staff. I will not sell my medications. I will not miss appointments. I will not smoke marijuana. My husband's an internal medicine physician and has been for over 20 years, and I am almost positive that he has never once refused to fill blood pressure medicines, insulin, or oxygen for his patients if they continue to smoke cigarettes, even though that tobacco is definitely negatively impacting their recovery from hypertension, diabetes, and chronic obstructive pulmonary disease. I might add that using marijuana, although it might negatively impact mental health, does not negatively impact the treatment for an opiate use disorder. If we have the stigma inside a mental health care company, imagine the stigma we have in our society. And stigma keeps people from staying healthy. Even in 12-step recovery groups, the place in the community where you're supposed to go get better, people are encouraged that if you're taking a medicine, you're just not quite ready to get better yet. So we don't know where to send them to get help among their peers. So what can we do about it? What can you do about it today? One thing is we can look at how we talk. You might notice that I'm using some words that seem kind of painfully awkward and big. And it is tough. If you've been in this field for a long time, we've developed a vocabulary saying things like addict, drugs, dirty urine. We've studied this for a very, very long time, and those words are stigmatizing. And we can do a patient case scenario and use appropriate words and inappropriate words and give them to the lay person, and they will always view appropriate words such as a person with a substance use disorder, a positive urine specimen, not using the words addict. When you give them that case study, they will always view that person more as someone who has an illness versus someone who did something wrong. So we need to clean up our mouths. We need to speak appropriately, and it is hard. It is hard. I work with lots of wonderful people at the Bowen Center who've been in this field for a long time, and they are empathetic and they are compassionate, but it is hard to change your language. John Kelly from the Harvard Medical School says, though, it's not a matter of being nice. It's a matter of making sure that when you speak correctly, then your patient starts speaking correctly about themselves too, and they stop feeling like they're a bad person, and they start realizing they're sick, and sick people get better. Bad people don't always do better. We can start learning a little bit about harm reduction. Deb McMahon's our health commissioner. She realized that Fort Wayne is struggling. We have way too many drug poisonings. We have way too many deaths from alcohol, complications from hepatitis C and cirrhosis. We have way too many deaths by suicide in this community. These are known as the deaths of despair, the reason that people ages 40 to 55's life expectancy is decreasing, not increasing. So she has been on the forefront of harm reduction, and harm reduction is not helping people use drugs, okay? People are going to use drugs regardless, okay? Harm reduction is helping people live so we can get them treatment. Harm reduction is helping people have some dignity in their lives. Harm reduction is helping them get help, medical care. Harm reduction is helping you, because when we decrease the incidence of hepatitis C and HIV, this community doesn't turn into Scott County, Indiana, where there was 164 cases of HIV in a 2-month time period. I'm a mom, and moms go to softball games. That's what we do. I've practiced for 21 years. I'm getting very good at it. And a couple weeks ago, I had an opportunity to go to a game, and I sat with a friend of mine who I've worked with for a long time until I moved up to the Bowen Center, and we talked about people that we've had the opportunity to work with for a long time in problem-solving courts, such as drug court, reentry court, mental health court. And it gave me a chance, as I was preparing for this, to look back and see, these are people that I took care of in 2011. And I would see them in jail as they came home from the Department of Corrections, or I would see them in my office as they came out of a county jail for some stints for bad behavior. And I did, in my heart of hearts, would say, I just don't think they're going to get it. You know, we can keep pouring on these services. We can keep sending them to the Department of Corrections. I don't think they're going to get it. But we'll keep trying. We'll keep trying. And now my conversation of that cohort of people was, can you believe they've been working at Chrysler for 3 years? Can you believe she's graduating from reentry court after her 3rd time of being in this? Can you believe that he's leading a Narcotics Anonymous meeting at 8 a.m. on a Saturday? Can you believe he's getting up at 8 a.m. on a Saturday? Can you believe that she has her kids back? And it reminded me, John Kelly from the Harvard Medical School says, it can take 5 to 6 times episodes of treatment to get one appreciable amount of recovery. It can take 8 years to get one continuous year of abstinence. If someone dies of an overdose, they will never experience that, okay? Being punitive, being kind, being authoritative does not work. It has not worked. It will never work. Empathy does not enable people to keep using, but it does enable them to get into treatment. And empathy comes from everybody, okay? It doesn't just come from me. It comes from the nurse. It comes from the person who checks them in the ER. It comes from the pharmacist. It comes from the pharmacist tech. It comes from the DCS caseworker. It comes from the neighbor who's encouraging and loving and caring and understanding. And if you can't do that, look at the person and pretend that they're your brother, your uncle, your grandparent. Don't check out until the miracle happens, because you might get to sit on the bleachers and talk to your neighbor and talk about someone you've been taking care of for 11 years and hear that they got their kids back. Thanks for letting me share today.